Going to have our lesson on gastrointestinal biliary tract disorder. Yeah, and that is, we have to check on the review of the GIT and then how we can assess conditions related to gastrointestinal tract. So it's supposed to be 22 hours up to the completion, but so these are the few objectives, and we shall be tackling bit by bit. We can't finish or finalize everything within the same moment for the 22 hours. So the first objective is that we are supposed to recall the anatomy and physiology of the GIT and related structure. And this has been a repeated notion ever since you are in primary. You in fact started by drawing it in nursery class. So then we shall describe common manifestations in patients with gastrointestinal tract disorders, describe the assessment of patients suffering from the GIT disorders, then describe disease condition of the GIT and their management. We are supposed to describe diseases condition of biliary tract and their management as well. And then we will review of GIT includes GIT and accessory digestive organs like teeth, tongue, salivary glands, liver, gallbladder, and pancreas. Shall as well check on digestions, including 6 basic processes, that is ingestion, secretion, mixing, and propulsion. Ingestion is to just swallow, secretion is to produce bodily substances, mixing and propulsion just that happen in your mouth when you mix food in your stomach, when they are mixed as well. So it takes a fortune, eh? Yeah, let's proceed from that. Okay, so then we shall also check on the mechanical and chemical digestion, absorption and defecation as well. Then histology, we shall be most of GIT from due to superficial. Shall check on the histology, the study of tissues of stomachs, tissues of alimentary canal, that is from the deep end of each structure to the most outside. Like what you're able to see from your end is that is just orientation of the structure of the alimentary canal. It shows you all the tissues that are structurally purported in order to construct that structure. Okay, so we have mucosa, the most deep. Then you gotta have submucosa following mucosa. Then you have muscularis. Those are just the membranous, the epithelial membrane that cut or structures the GIT. So I'll start with the mucosa, then submucosa, then muscularis, then adventitia, which you can also call the serosa. So innervation. Let's check on innervation. When I say innervation, is how the nerves, birth and supply or connect the gastrointestinal tract. Remember, innervation is very, very important. When nerves are all over your body, you're able to feel all your parts, you're able to control all of them, and any other mechanism, be it voluntarily or involuntarily, will be appropriate and very, very effective. In a way that if there is no nerves within your stomach, then you have a stomach ache. You won't realize there's a problem in your stomach because there will not be pain, perception and sensation. And so you will just be relaxed until everything goes wrong. Is when now you are dying. So the innervation on the nervous system, the both peripheral nervous communicating with the central nervous, they are key things to the motor, and they are also key things to adhere to what sensory receptors are getting or receiving. So in the enteric nervous system, they are called enteric because of all that they have something to do with the intestines, yeah, right? So we have the myenteric or the Haubach plexus, that is on the it attaches to the muscularis. It regulates the GI tract motility, and it therefore will tell you if the Haubach plexus is interferes with, you will be having IO. IO is a clinical condition manifested with 4 cardinal signs. IO is called intestinal obstruction. It always due to mostly the GIT tract motility being, unable to work accordingly. So it is resulting to blockage or maybe obstruction of the flow because there is no movement in your gastrointestinal tract, and therefore you'll be presenting with distended stomach, the sense of vomiting, abdominal pain, yeah, and so on and so forth. So that is if the Auerbach's plexus is interfered with, or the mesenteric nerves. Another one is submucosal or Meissner's plexus. The submucosa, it regulates the gastrointestinal secretion. It regulates all the gastric juice or the other enzymes that are produced within the GIT. So that is to mean that their motor ending, or their afferent receptors, or let's say the motor neurons, are attached to the glands. So with their stimulation, they can either trigger or activate a gland to secrete a substance that is of key importance in digestion process. Like, let's say now the gastric gland secreting gastric juice, which has got hydrochloric acid, which will be neutralizing any pathogenic substance and also activating other enzymes along. So autonomic nervous system is another class of innervation, and we have parasympathetic fibers of the vagus and spinal nerves, increasing gastrointestinal secretion and motility. So what mostly you need to know, when you say parasympathetic fiber, normally it attributes the antagonism of the sympathetic fibers. But remember, when parasympathetic could given impulse, like let's say it reduces gut motility in a given way, sympathetic increase, but now not that effectively, that you need to know where some places sympathetic is supposed to be increasing the speed of or the effect, the para will be now lowering it down, and it's not constant. You'll find this place sympathetic is the one which is increasing, the other place you get, like for instance in your cardiac muscle, sympathetic are very key in triggering and keeping up the pace, while parasympathetic now lowering the firing of the impulse and therefore heartbeats. Now on the GIT, you realize that now is the opposite, because parasympathetic fibers now increases the secretion and motility, while the sympathetic now decreases in that case. Yeah, so you need to know that not the factor that these nerves communicate using neurotransmitters. These neurotransmitters are effective in a different way, and they're functionally differing from one receptor to another. So in the receptor of the cardiac, we have a different form of action, and the receptor of the GIT is also different. So blood supply is another thing we need to know. That esophagus, esophageal artery is the main supply in the esophagus. Then abdominal pelvic organ, we have the celiac artery, the superior and inferior mesenteric arteries. And you should know what are the superior branches of superior mesenteric arteries and which organs do they supply. The inferior mesenteric arteries also supposed to be, you conclude and know the organs and the branches of the arteries. Colic arteries, you should also know if it is spleen, if it is gastric, whatever. You need to know which organs are bathed by celiac, whatever artery, right? Drainage, check on the drainage esophagus. We have the esophagus. So drainage is what now remove the blood. We have esophageal veins. Abdominal pelvic, we have the portal vein. And then the portal vein is the greater one, which even goes into the liver. Lower rectum and the anus, we have the internal iliac veins. So that structure you're able to see from your hand is just a vindication of everything. Yeah, we've just talked about it. So this everything that we've discussed, and I'm very happy that you're able to see it from your hand if you're using the YouTube. The structure of your teeth, the mouth. Then you have the esophagus. You have constriction, peristalsis wave, bolus, relaxation. How that takes place, you'll see it later, right? And that is a very good anatomical view of the histology of stomach. You see the saccular muscle, the oblique muscles, right? And then you get the submucosa and then the mucosa. You know, we have the gastric rugae, that are the inner lining or coiling of the stomach. Their main function, the rugae, are supposed to be, they are called so that when the stomach is full, when it distends, they are able to uncoil and increase the space for more packaging. We have longitudinal muscles and circular muscles. In some places they work always in the shape to allow distension and contraction when the chyme is being mixed in the stomach. We have cardia part of the stomach, fundus part of the stomach, and the pylorus part of the stomach. Don't forget about the body. So like you need to know the secretion. The goblet cells will always secrete mucus. Parietal will secrete hydrochloric acid intrinsic factor. Chief cells will produce pepsinogen. Subset parietal cells will produce HCl and intrinsic factor. Then the sheath cells also in the stomach will produce pepsinogen. Heterochromaffin will produce histamine and serotonin. Histamines are the what called the autocoids. Autocoids in our body, their main function is to remedize a condition which has gone worse. For instance, when you talk about autocoids, the key interesting part that you need also to get to understand is that the autocoids are produced by our body. They are endogenous substances, like for instance histamine, serotonin, platelet activating factors, the thrombosin, the prostaglandin, all those ones, be it lipid, be it peptides, in a way, they help in remedizing a condition which has gone wrong. Instantly, histamine will be released in case there is hypersensitivity or what we call the allergy, which can result to anaphylactic shock. So when they are released, they normally mediate and they bring more of the allergy. It's like, the allergy and inflammatory reactions. These are just always to enable your body cope with the undesirable situation. So when the histamine is released, it's supposed to be, precipitating the allergy so that something wrong is supposed to be elevated. Like instantly you realize when the histamine is released, you will have pruritus, you will be like having rash on your skin, there will be overproduction of mucus in your bronchioles, there will also be bronchospasm, right? Yeah, you'll get to be like red eyes, sort of. So these allergic reactions, they are mainly to enable, if it is a bacteria in your bronchus, supposed to be swept on by over the secretion of mucus, and then doesn't end with the, so they are always remaining, but now they bring on worse than what is expected, right? For instance, now after histamine is secreted, you get to see obvious clinical manifestation which now requires medication attention. Stably serotonin as well, but now when it comes to the serotonin is another case, but yeah, you see serotonin at most, they will always work responsibly, but at some point they now exaggerate. Like serotonin is used in your brain. Yeah, it's also a precursor of making the melatonin, which is a sleep cascade, the circadian rhythm, which monitors your day and night awakening cycle. So in a physiological way, it's very important. But now when it's over-secreted, it also brings on things to do with MSCs, what. So it has also a disadvantage on the other way. So histamine and serotonin also are released in the stomach by the enterochromaffin like cells. I remember once in a while there was an exams, and the exams was like asking, where do we find 90% serotonin? And then that's supposed to be in the enterochromaffin in your body. So like, yeah, you need to know these things, what you're saying, if you'll remember them. So histamine in the case, yeah, we said their main function is to initiate some digestion procedures, yeah, like protein digestion. Serotonin as well increases also even the appetite and so on and so forth. So G cells and the D cells, the gastrin cells and the D cells will produce somatostatin, and the gastrin cells will produce gastrin. Gastrin are hormone, somatostatin is also an hormone which also help. Like for instance, why are these hormones over secreted? You remember when is protein being digested, there must be other activities coming in, like secretion of HCl or the pepsinogen, right? The renin. So there's how these two hormones play a role. When the digestion in the stomach is done, we should reduce the release of given hormone, let's say gastrin, so that the HCl should stop. And that release of gastrin will reduce somatostatin release, and therefore the pylorus or the end of the stomach will open, allowing the substance to move. So there's that cascade or circle that enable content to stay in the stomach for some time. After digestion, then they are left to move and flow. That's the structure of what I was talking about. left lobe of liver, common. You need to know the round ligament, the common bile duct. That is called the CBD, right? The common bile duct will have like itself linked to the cystic duct, the left hepatic duct, right? Yeah, and so these important features all back of liver are very good, right? Hepatic duct, and you also need to know which one but the left lobe, the right lobe, the quadrate lobe, right? And you also need to know when you'll be doing the clinical pathology, you'll see condition related to cystic duct, and so on and so forth, right? So let's proceed. Similarly, you can view the image of the intestine, the mesentery supply. Blood supply, the ileum, the appendix. These are just structural review of what we are supposed to learn over in this one. Absorption sites: calcium is absorbed there, magnesium, iron is released and absorbed in the blood. Disaccharides are also living, water soluble. You see, you need to know which specific regions, and then you can have a break. The break is over. We're going to have a different scenario. We are supposed to proceed with assessment of GIT. And in the assessment of GIT, see, things that we are really supposed to understand or maybe get into our attention is that history and assessment GIT will give us a complete or definitive diagnosis if we do it meticulously. So first of all, the history, you have to consider the changes in the bowel habits, evaluate dietary patterns and fluid intake, weight loss or gain, pain, nausea, vomiting, those are key things, presence of problems with flatulence, medication history, and a previous GI related surgery. So let's start with assessment of GIT. Physical examination. First thing, vitals and general condition, check them. As for pain, oral cavity, check them very well. You see presence of the oral thrush, any ulceration, glossitis, that is inflammation of the tongue, right? Even if you have the angular glossitis, you see there is some corridor of your mouth, the corner of the end of your mouth can have some whitish things. They are presenting always angular glossitis, right? We have many aspects of oral that we're supposed to check over, even the dental orientations, types of the conditions of the teeth. Then you go to the abdomen inspection. When you inspect, you use your eyes. That is why the IPPA is supposed to be inspection, palpation, percussion, and auscultation. But remember, these techniques are normally changing depending with the system that we are checking. So for instance, when you talk about inspection, you check on the stomach, whether it is flat, round, or distended. That's the first thing you need to know. Also in the inspection, you can be keen enough to see any pulsation. And away from that one, there are some conditions that like the gravis, the nigra gravis, or what we call, there's a spider nevy, the spider nevy, which is always manifested when somebody has got chronic liver failure, right? So you see there are those spread of veins all over the stomach and the abdomen. You see on the skin, that is done by inspection. Previous scar can also be seen by the inspection, whether there was any surgical previously done to the patient. So inspection is still key. Then for the stomach, the way I said, the IPPA is supposed to change in some system. So per abdomen or the per abdomen in assessment or examination, after inspection you go directly to auscultation. Why don't we go to palpation, then percussion, then auscultation? Because after you've done the percussion and palpation on your abdomen, you will interfere with the bowel sounds. And the bowel sounds, once you tap your stomach and you interfere with them, you won't get your clean results or maybe conclusion on your investigation. So first you go to auscultation, and then you listen before you touch. You make sure you listen. You can use stethoscope, right? Yeah, and then you put them. So you'll check on the bowel sounds. We have the brute sounds. The brute sounds are produced almost next to the diaphragm, and they always also called the aortic sound. So they are the sounds of the heart to be spreading over in the low or what we call the abdominal aorta. The bowel sound, we also have the bowel sounds. Apart from the brute sounds, we have the lower bowel sounds, which are indicative of what we call when you have the obstruction or the intestinal obstruction. Yeah, you'll get to rule in or rule out some of the conditions, maybe the intestinal obstruction. So then absent, when they are absent, that is hypoactive. When they're active or present, we call them hyperactive, right? So we can have absent, haiko kabisa, hypoactive, or they can also be active, and or hyperactive. So active is common, right? This condition that is also manifested by the absence of the vowel sign, by something. So you gotta have that and check when there is that absence of the vowel sound. Then you have to conclude there is intestinal obstruction. Therefore, you're supposed to initiate the management of IO, like now using enema to flush out. Yeah, if it is obstruction interfering in terms of the aperture on the structural basis, like now it has to do with hernia, you will call for the surgical management. Percussion is coming next, and when you percuss, we normally tend to hear the sounds. So we can check on the whether there is air in the stomach or fluid in the stomach, but the sound that the percussion produce. So when you percuss, you use the single percussion technique, and then you'll get to hear whether there is air or the fluid by tapping on the stomach parameter. There is how you're supposed to tap it. You'll check in YouTube how you're supposed to percuss it. Then you're gonna have palpation. And the palpation is shallow, deep. You can use shallow method and deep method. You first start by shallow, just on top, and by that you will also see, keep on monitoring the face of the patient to see if there is any pain resulting, or what we call the tenderness. When there is sign of guarding from the patient, that is, the place is very painful, there is tenderness, and therefore you should stop or maybe consider different method. Then go to deep. If you've considered shallow, now end up doing deep palpation. And when you're doing deep palpation, ensure that you note the structural orientation of abdominal organ, the size of the spleen, the size of the stomach, right, the intestine, if they are in any way herniated. So that is that. Then you go to rectal and anal areas. So regions of the abdomen are classified based on the quadrants. We have the right upper quadrant, the right lower quadrant, the left upper quadrant, the left lower quadrant. And then there is that classification based on quadrant, and there's 9 region classification. So the 4 quadrant is one, and then there's another category of classification of stomach based on the 9 region. The first region is the epigastric region, followed by umbilical region. Then we gotta have the hypogastric region. Then we start with the right hypochondriac region, left hypochondriac region, the right lumbar region, left lumbar region, right inguinal region, and left inguinal region. So you're gonna have to know which organs are found on those places. So what you are seeing there is very nice to use, and you can also come over and use videos. We had videos here, and they are very key videos, and so they will help you. If you click them right here, you can play them, but that's wastage of time. So you can go to Medical Students Arena and click 1.2 under biliary and axillary and the digestive system, and you'll get to see all these videos. Watch your able, you click and watch them. Common manifestation of GIT disorders, that is next, but here we head from here, and then we'll start by common manifestation of GIT disorders in the next lesson. Thank you so much for for availing yourself of being present today, and then let's have a nice moment. Keep up with Medical Students Arena. Share such YouTube video to many of your colleagues. Interact with them and tell them how we work, and then it will be of great importance and beneficial to your friend as well. This is Dr. Uma presenting. Have a nice time, and don't forget to do the same exams in the portal. Thank you.